So today I will be voicing over your PowerPoint for chapter 47 and 49, assessment of the endocrine system and problems with the endocrine system. So here we can see the image that we have in our book of the structures and functions of the endocrine system. So the endocrine system is a complex network of glands and organs. It uses hormones to control and coordinate your body's metabolism, energy level, reproduction, growth, and development, in response to injury, stress, and mood. The following are integral parts of the endocrine system. So we have the hypothalamus. The hypothalamus is located at the base of the brain near the optic chiasm, where the optic nerve behind each eye cross and meet. The hypothalamus secretes hormones that stimulate or suppress the release of hormones in the pituitary gland, in addition to controlling water balance, sleep, temperature, appetite, and blood pressure. The pineal gland, or the pineal body, is located below the corpus callosum in the middle of the brain. It produces the hormone melatonin, which helps the body know when it's time to sleep. The pituitary gland is located below the brain, usually no larger than a pea. The gland controls many functions of the other endocrine glands. Thyroid and parathyroid. These glands are located in the front of the neck below the larynx or the voice box. The thyroid plays an important role in the body's metabolism. The parathyroid gland plays an important role in the regulation of the body's calcium balance. The thymus is located in the upper part of the chest and produces white blood cells that fight infections and destroy abnormal cells. The adrenal gland is located at the top of each kidney. Like many glands, the adrenal glands work hand in hand with the hypothalamus and pituitary gland. The adrenal gland make and release corticosteroids, a hormone, and epinephrine that maintain blood pressure and regulate metabolism. The pancreas is located across the back of the abdomen, behind the stomach. The pancreas plays a role in digestion as well as hormone production. Hormones produced by the pancreas include insulin and glucagon, which regulate levels of the blood sugar. The ovaries, which are found in women, are located at both sides of the uterus below the opening of the fallopian tubes, in addition to containing the egg cells necessary for reproduction. The ovaries also produce estrogen and progesterone. And on the previous slide, I did not add testes. These are the man's testes located in the pouch that hang suspended outside the male body. The testes produce testosterone. So the hormones that are produced within these glands are going to be important, and you should know the majority of these because these are, if these are affected in our body, then that's what's going to cause issues. So hormones are chemical substances made by the endocrine gland that control and regulate the activity of certain target cells or organs. Many are made in one part of the body and control and regulate the activity of certain cells or organs in another part of the body. The thyroid gland makes the hormone thyroxine, which affects many body tissues when released directly into the circulation. Other hormones act locally on cells where they are released and never enter the bloodstream. We call this local effect paracrine action. The action of sex steroids on the ovary is an example of the paracrine action. Most hormones have common characteristics, including 1, secretion in small amounts at a variable but predictable rate, 2, regulations by feedback systems, and 3, ability to bind to specific target cell receptors. If you look in your book at table 47.1, this will review the major hormones, and these are the ones you'll see on this one and the next slide. It's very important to know these hormones, how they work with the body and with the organs. There's a strong connection between the endocrine and the nervous system. Catecholamines, or such as epinephrine secreted by the adrenal gland, travel through the bloodstream and affect multiple organ systems. These same substances, when secreted by the nerve cells in the brain and the peripheral nervous systems, act as neurotransmitters, sending important impulses across the nerve synapses. Organs can act as endocrine glands by secreting hormones. For example, the kidneys secrete erythropoietin, a substance that stimulates red blood cell production. The heart secretes atrial natriuretic peptide, or ANP. The gastrointestinal tract secretes many peptide hormones like gastrin that aid in digestion. Again, just review these hormones and the organs they work with. So let's look at some considerations for our older adults. So normal aging has many effects on the endocrine system. These include decreased hormone production and secretion, altered hormone metabolism and biologic activity, decreased responsiveness of target tissues to hormones, and changes in cardiac rhythms. Assessing the effect of aging on the endocrine system may be difficult because the subtle changes of aging may mimic manifestations of endocrine disorders. Endocrine problems may manifest differently in an older adult than in a younger adult. Older adults may have multiple comorbidities and take medications that change the body's usual response to endocrine function. Symptoms of endocrine problems such as fatigue, constipation, and mental impairment may be attributed to aging, resulting in delayed treatment. So assessment of the endocrine system. So endocrine problems generally result from too many or too little of a specific hormone. The onset of symptoms is often gradual. Subtle or vague symptoms are often attributed to other physiological or psychological causes. Patients may present with fluid and electrolyte imbalances, altered tissue cohesion, inadequate coping mechanisms, changes in heart rhythm, or changes in skin integrity that can be interpreted as many other conditions. Alternatively, patients may present with acute symptoms that are life-threatening and demand immediate intervention. So looking at subjective data, as information obtained from the patient can provide important clues as the functioning of the endocrine system. You will need to obtain a thorough history from the patient and or caregiver if the patient's mental acuity is compromised. So things we're going to look at is past health history. A patient with endocrine disorders often present with non-specific complaints. The chief complaint may relate to not just one, but a group of symptoms. The most common presenting problem includes fatigue, weakness, menstrual irregularities, and weight changes. It is important to determine if the onset of symptoms has been gradual or sudden, and what the patient has done about them. Because some of the more general signs of problems are the easiest to overlook, we must evaluate any reported or observed changes in weight, appetite, skin, libido, mental acuity, emotional stability, or energy levels. Medications. We're going to ask about the use of medications, both prescription and over-the-counter. Herbs and dietary supplements can alter hormone balances. Ask about the reason for taking the drug, the dosage, and the length of time the drug has been taken. In particular, ask about the use of hormone replacements. Knowing the patient is currently taking hormone replacements such as an insulin, thyroid hormone, or corticosteroid like prednisone should alert you to potential adverse drug events. For example, corticosteroids may increase blood sugar levels and cause bone loss with long-term use. Thyroid preparations may cause tachycardia or dysrhythmia. Drug-to-drug interactions and adverse effects of non-hormonal medications can contribute to endocrine problems. Surgeries or other treatments. So ask about past medical, surgical, obstetric history, including numbers of pregnancies and live births. Assess growth pattern and stages of physical and emotional development. For example, knowing about radiation therapy to the head and neck is important when you suspect thyroid and pituitary problems. We're also going to look at multiple endocrine neoplasia, which is like if they have a history of endocrine cancers, and if they have a history of diabetes mellitus. So, functional health patterns. So, key questions to ask the patient with an endocrine problem are outlined in your book on table 47.4. Gives you very specific questions that you can ask your patient based on each system of the body. Hereditary plays a key role in the development of endocrine problems. Ask about first-degree relatives with diabetes, thyroid disease, or endocrine gland cancers. Since these conditions have a familial tendency, a genetic assessment of family members may be needed. Nutritional metabolic pattern. Changes in appetite and weight can indicate an endocrine problem. Ask about a history of weight distribution and changes. Weight loss with increased appetite may occur with hyperthyroidism or diabetes. Weight gain may occur with hypothyroidism or hypocortisolism. Obese persons are more likely to develop type 2 diabetes. Asked if there has been a problem with nausea, vomiting, diarrhea, and enlarged thyroid gland can cause difficulty swallowing or a change in the neck size. Increased SNS activity, including nervousness, palpitations, sweating, and tremors may occur with thyroid problem or a rare tumor of the adrenal medulla. Heat or cold intolerance occur with hyperthyroidism or hypothyroidism, respectively. Ask about changes in the patient's skin, especially on the neck, face, hands, or body creases. Changes in skin texture and skin that seems thicker or drier may suggest an endocrine problem. A patient with hypothyroidism or excess growth hormone may have skin that feels coarse or leathery. Ask if the patient has noticed any changes in the hair of anywhere on the body. Elimination patterns, we're going to begin maintaining fluid balance is a major role of the endocrine system. Questions related to fluid intake and elimination patterns may uncover endocrine problems. For example, increased thirst and urination can indicate diabetes, such as pancreatic disorder, or diabetes insipidus, which is a pituitary disorder. And you'll talk more about that in level 2. Ask about the frequency and consistency of bowel movements. Diarrhea can occur with hyperthyroidism and thyroid cancer. Constipation occurs with hypothyroidism, hypoparathyroidism, hypopituitarism. Activity exercise pattern, you're going to determine if there is any acute or gradual changes in the energy level or persistent fatigue. A patient with chronic fatigue secondary to hypothyroidism, hypocortisolism, or diabetes may report changes in activity level. Sleep rest pattern, we're going to ask the patient how many hours they typically sleep and if they feel rested or on awakening. Sleep patterns can result from nocturia, nightmares, anxiety, depression, or insomnia that occur with diabetes or thyroid problems. Cognitive perceptual pattern, memory deficits may occur with hypothyroidism and changes in sodium levels. Inappropriate secretions of antidiuretic hormones, or SIADH, or pituitary tumors can cause hyponatremia. These issues can occur gradually. Gathering information from the patient and family about memory, cognitive abilities, and balance can increase the chances of an earlier diagnosis. Self-perception, self-concept pattern. Many endocrine disorders may affect a patient's self-esteem because of associated changes in their physical appearance. For example, weight gain associated with hypothyroidism or exophthalmos and goiter associated with hyperthyroidism can cause problems related to the body image. Role in relationship pattern. Questions related to roles in relationships can highlight depression, chronic fatigue, and sleep patterns. With chronic fatigue, depression, and anxiety, patients and their families will have stressed relationships. Questions related to home and life and patients' ability to fulfill their role in the family will aid in identifying problems. Sexuality and reproductive pattern. The endocrine system regulates growth hormone, prolactin, luteinizing hormone, follicle-stimulating hormones, and testosterone and estrogen. Therefore, menstrual problems, hirsutism, infertility, decreased libido, and growth disorders can be a result of the endocrine disorder. Some women develop hypothyroidism during or after menopause. Other patients begin to develop type 2 diabetes during middle age when sex hormones are changing. Document the presence of abnormal secondary sex characteristics such as facial hair, which is hirsutism in women. Obtain a detailed history of menstruation and pregnancy. Menstrual problems can occur with disorders of the ovaries and pituitary, thyroid, and adrenal glands. A history of large birth babies or gestational diabetes increase the risk for developing type 2 diabetes later in life. Male sexual problems may include impotence, infertility, or the lack of development of secondary sexual characteristics. Retrograde erections can occur in diabetes. Coping and stress tolerance patterns. Because stress worsens some endocrine conditions, ask patients about their stress level and usual coping patterns. Patients with adrenal insufficiency have difficulty learning with stress, or difficulty dealing with stress. These patients are at risk for developing hypertension and fluid electrolyte imbalance. And value and belief pattern. Determining a patient's ability to make lifestyle changes and an important nursing function. Identify the patient's value belief pattern so that you can help to determine appropriate treatment plans. This is especially important in conditions such as diabetes, which may require major lifestyle changes. Other disorders such as hypothyroidism or hypercortisolism may be managed with medications that need lifelong monitoring. So objective data, except the thyroid and testes, most endocrine glands are inaccessible to direct examination. Assessment can be accomplished using objective data from physical examination and diagnostic testing. It is essential to understand the actions of hormones in order to assess the function of the gland by monitoring the target tissue. So on physical examination, use the following general examination when evaluating endocrine function. Specific clinical findings for the various endocrine problems are discussed in Chapter 48 and 49. Endocrine disorders may cause changes in mental and emotional status. Throughout the examination, assess the patient's orientation, alertness, memory, cognitive abilities, affect, like their facial affect, personality, and appropriateness of their behavior. Take a full set of vital signs at the beginning of the examination. Variation in temperature, heart rate, heat, can occur with a variety of endocrine-related problems. Obtain height and weight, calculate their BMI to assess nutritional status. Integumentary, so assess the color and texture of the skin, hair, and nails. Note the overall skin color as well as the pigmentation or bruising. Decreased skin pigmentation can occur with hypopituitarism, hypothyroidism, and hypoparathyroidism. Hyperpigmentation or bronzing of the skin, especially on the knuckles, knees, elbows, genitalia, and palmar pieces, is a classic finding in forms of adrenal insufficiency known as Addison's disease. Palpate the skin for texture, moisture, examine hair, distribution on the head, face, trunk, extremities. Assess the skin's or the hair's appearance and texture. Hair loss, excess hair growth, or dull, brittle hair may suggest endocrine problems. Assess for delayed wound healing. Head, you're going to inspect the size and contour of the head. Facial features should be symmetrical. Hyperreflexia and facial muscle contractions upon percussion of the facial nerve, which is the Vogt sign, may occur in hypoparathyroidism. Inspect the eyes for position, symmetry, and shape. Large and protruding eyes, exophthalmos, are associated with hyperthyroidism. Assess visual acuity using Snellen eye chart. Visual field loss may occur with pituitary tumor. In the mouth, inspect the buccal mucosa, condition of the teeth and tongue size. Note hair distribution on the scalp and face. Hearing loss is common in acromegaly from excess growth hormone. Neck, we're going to look at the thyroid gland to see if it should not usually be visible upon inspection. A feature that distinguishes the thyroid from other masses is the neck as up in an upward movement and on swallow. Let's start with the neck again, sorry. The thyroid gland is not usually visible during inspection. A feature that distinguishes the thyroid from other masses in the neck is its upward movement on swallowing. Inspect the neck while the patient swallows a sip of water. The neck should appear symmetrical without lumps or bulging. Palpate the thyroid for its size, shape, symmetry, and tenderness, and for any nodules. A goiter is an enlarged thyroid gland. Can occur with hyperthyroidism or hypothyroidism. Be careful not to press too hard or massage an enlarged thyroid gland. This can cause a sudden release of thyroid hormone into an already overloaded system. An experienced clinician should perform palpation in patients with no diagnosis of hyperthyroidism. The extremities, assess the size, shape, symmetry, and general appearance of the hands and feet, and their proportion of the hands and feet. Patients with acromegaly, prone pituitary tumors, may have large hands and feet. Inspect the skin for changes in pigmentation, lesions, and edema. Assess muscle strength and deep tendon reflexes. In the upper extremities, assess for tremors by placing a piece of paper on the outstretched fingers. Calm down. Muscular spasms on the hand elicit an application of an occlusive BP cuff for 3 minutes. This is to show signs may occur in hyperparathyroidism. Genitalia, inspect the genitalial hair distribution patterns since it may be changed with hormone problems. Assessment abnormalities related to the endocrine system are outlined in Table 47.5. A focus assessment of the endocrine system is shown on page 1101. So when you perform palpation for a goiter or just palpating the thyroid, you're going to use a posterior or anterior approach. For the anterior approach, you're going to stand in front of the patient with the patient's neck flexed. Place your thumb horizontally with the upper edge along the lower border of the cricoid cartilage. Then move your thumb over the isthmus as the patient swallows water. Allow your fingers laterally to place your fingers laterally to the anterior border of the sternocleidomastoid muscle and palpate. Each lateral lobe below, and while the patient swallows water, you're going to palpate. For posterior palpation, stand behind the patient with the thumb of both hands resting on the nape of the patient's neck. Use your index and middle fingers of both hands to feel the thyroid, isthmus, and 4 interior surfaces of the lateral lobes. To reflex the neck muscles or relax the neck muscles, ask the patient to flex the neck slightly forward to the right and to the right. Displace the thyroid cartilage to the right with your left hand and fingers. Palpate with your right hand after placing the thumb deep and behind the sternocleidomastoid muscle with the index and middle fingers in front of them. Ask the patient to swallow water and feel for the thyroid to move up. In a normal person, the thyroid is often not palpable. If palpable, it usually feels smooth with a firm consistency. It is not tender with gentle pressure. If nodules, enlargements, asymmetry, and hardness, which are abnormal findings, are present, refer the patient for further evaluation. Auscultate the lateral lobes of the enlarged thyroid gland with a stethoscope bell to hear a bruit, a soft swishing sound that can occur with a goiter or hyperthyroidism. So for diagnostic studies, I want you to look in the book at table 47.6 and 47.7. You're going to need to know the normal levels of glucose, fasting, non-fasting, mid TSH, T4, free T4, and T3. You should know those levels because those are the most common levels that you're going to see assessed when you're looking at thyroid conditions. So we're going to look at an NCLEX style question here. A patient with a serum calcium level of 13.4. Which disorder could the nurse suspect? Okay, so remember we talked about calcium and hypocalcemia, hypercalcemia. So now we know it can be related to certain disorders. So going back and looking in your book, you would have to review and see that the most common reason for having this level of calcium in the body is going to be related to hyperparathyroidism. Because your normal calcium level is 8.6 to 10.2, and this patient has a 13.4, so it has hypercalcemia. And you're going to see increased serum calcium levels with hyperparathyroidism. A patient with thyroid nodules is to undergo a thyroid scan with oral radioactive isotopes. Which instructions, if given by the nurse, are appropriate? The test cannot be completed if you have an allergy to iodine or shellfish. It is important to drink at least 2 to 3 liters of water for the next 1 to 2 days. Isolation is required for 24 hours until the radioactive substance is gone from the body. Sedation is necessary to ensure that you do not move while the scanner moves over the neck. So, of course, you're going to have to look at what we do and our indications and nursing interventions are for when someone has thyroid scan done with radioactive isotopes. So this is different than our radioactive iodine therapy. Okay, this is different. This is just where we're testing first to see if we have any issues. So with this one, it is very important to make sure that a patient is drinking 2 to 3 liters of liquid for the next 1 to 2 days. Okay, no special precautions are needed. The radionuclide will be eliminated in 6 to 24 hours. Reaction to iodine in an allergic patient is rare because the amount of iodine in preparation is very minimal. Sedation is not necessary for this procedure. So a patient has signs of hypothyroidism. Which diagnostic test will the nurse expect to be done first? So with hypothyroidism, with hypothyroidism, our first test is always going to be the TSH. Usually when you say you're going to do the thyroid panel, the most common thing is the TSH is done first. Some doctors will then go ahead and reflex to the free T4 and T4 if it comes back elevated or low. Sometimes they do not. It just depends on the provider. So the most sensitive and accurate laboratory test is the measurement of TSH. It is often recommended as the first diagnostic test for evaluation of thyroid function. If the TSH is abnormal, the other laboratory tests may be ordered. So now we're going to move on to some endocrine problems. We're going to touch on mainly hypo and hyperthyroidism. Your book does go into depth on a few other disorders, and these disorders may be covered in the NCLEX, so I do encourage you, to review them. But with the content we need to cover this week, I did not want to go into depth with each one specifically. But just know you could be tested over them on the NCLEX, so I do encourage you to review the full chapter. Okay, we're going to talk about hyperthyroidism. So it's a problem with thyroid function. Problems with thyroid function are among the most common endocrine disorders. The thyroid hormones thyroxine T4 and tritothyronin or ronine T3 regulate the energy metabolism and growth and development. Disorders of the thyroid gland include goiter, benign, and malignant nodules, inflammatory conditions leading to hyperthyroidism and hypothyroidism. Hyperthyroidism is an innate hyperactivity of the thyroid gland with sustained increase in synthesis and release of thyroid hormones. It occurs in women more than men, so the highest frequency in persons 20 to 40 years of age. The most common form is Graves' disease. Other causes include toxic nodular goiter, thyroiditis, excessive iodine intake, pituitary tumors, and thyroid cancer. Since hyperthyroidism may be caused by iodinated contrast media used in CT scans and other radiological studies, monitor those who are at risk closely after iodinated contrast media exposure. The term thyrotoxicosis, there we go, refers to the physiological effects or clinical syndrome of hypermetabolism resulting from the excess circulating levels of T3, T4, or both. Hyperthyroidism and thyrotoxicosis usually occur together. Subclinical hypothyroidism occurs when the patient has a serum TSH level below 0.4 milliunits per liter, but normal T4 and T3 levels. Overt hyperthyroidism is defined by low and detectable TSH and increased T4, T3. The patient may or may not have symptoms of hyperthyroidism with overt hypothyroidism. Etiology and pathophysiology is mixed. So with etiology and pathophysiology of Graves' disease, it's an autoimmune disease of an unknown cause characterized by diffuse thyroid enlargement and excess thyroid hormone secretion. It accounts for 75% of the cases of hypothyroidism. Causative factors such as lack of iodine, smoking, infection, and stressful life events may interact with genetic factors to cause Graves' disease. In Graves' disease, the patient develops antibodies to the TSH receptors. These antibodies attach to the receptors and stimulate the thyroid gland to release T3, T4, or both. The excess release of thyroid hormones leads to the manifestations associated with thyrotoxicosis. The disease is characterized by remissions and exacerbations with or without treatment. It may progress to destruction of the thyroid tissue, causing hypothyroidism. Graves' disease is associated with the presence of other autoimmune disorders, including rheumatoid arthritis, pernicious anemia, systemic lupus erythematosus, Addison's disease, celiac disease, and vitiligo. So clinical manifestations we'll see. The manifestations are related to the effect of excess circulating thyroid hormone. It is directly increased metabolism and tissue sensitivity to sympathetic nervous system stimulation. Palpation of the thyroid gland may reveal a goiter. When the thyroid gland is excessively large, a goiter may be seen on inspection. Auscultating the thyroid gland may reveal bruits of a reflection of increased blood supply. Another common finding is ophthalmopathy, a term used to describe abnormal eye appearance or function. A classic finding in Graves' disease is exophthalmos, a protrusion of the eyeballs from the orbits that is usually bilateral. This results from an increased fat deposit and fluid or edema in the orbital tissue and ocular muscles. The increased pressure forces the eyeballs forward. The upper lids are usually retracted and elevated, the sclera visible above the iris. When the eyelids do not close completely, the exposed corneal surfaces become dry and irritated. Corneal ulcers and loss of vision can occur. Changes in the ocular muscles result in muscle weakness, causing diplopia or double vision. Other manifestations are outlined in Table 49.6. Abnormal laboratory findings are listed in Table 49.7. A patient in the early stages of hyperthyroidism may only have weight loss and increased nervousness. Acropatchy or clubbing of the digits may occur with advanced diseases. Manifestations such as palpitations, tremors, and weight loss in older adults do not differ significantly from those of younger adults. In older patients who are confused and agitated, dementia may be suspected and delay the diagnosis. So here is a picture of someone who has exophthalmos and a goiter, both. So in your book, you're going to review Table 49.6. This is going to go over both of these next two slides. Here's a picture of the acropatchy, which is the clubbing of the fingers related to hyperthyroidism. So comparison of younger and older. So you can see this table is going to go through and break down the comparison of the causes, symptoms, if there's a goiter, the ophthalmopathy, and any cardiac features. So we'll just review that table. Diagnostic studies. The primary laboratory findings used to confirm the diagnosis of hyperthyroidism are low or undetectable TSH levels, an increased free T4, and total T3 and T4 also may be assessed, but they are not as definitive. Total T3 and T4 determine both free and bound to protein hormone levels. The free hormone is the only biological active form of these hormones. The RAIU test can distinguish Graves' disease from other forms of thyroiditis. The patient with Graves' disease shows a diffuse homogeneous uptake of 35 to 95%, while the patient with thyroiditis shows an uptake of less than 2%. The person with a nodular goiter has an uptake in the high normal range. So what are some goals? So the goal of management is to block the adverse effects of the excess thyroid hormone, suppress oversecretion of the thyroid hormone, and prevent complications. There are several treatment options, including antithyroid medications, radioactive iodine therapy, and surgical interventions. Supportive therapy is directed at managing respiratory distress, reducing fever, replacing fluid, eliminating or managing the initiating stressor. The choice of treatment is influenced by the patient's age and preferences, coexistence of the other diseases, and their pregnancy status. So drugs used to treat hyperthyroidism include antithyroid drugs, iodine, and androgenic blockers. These drugs are used in treating thyrotoxic states, but are not curative. Radiation therapy and surgery may be needed. So with radioactive iodine therapy, it is a treatment of choice for most non-pregnant adults. RAI damages or destroys thyroid tissue, thus limiting thyroid hormone secretion. It has a delayed response. The maximum effect may not be seen for up to 3 months. For this reason, the patient is usually treated with anti-thyroid drugs and propranolol before and for the 3 months after starting RAI until the effects of the radiation become apparent. Although RAI is usually effective, 80% of patients have post-treatment hypothyroidism, resulting in the need for lifelong thyroid hormone therapy. Teach the patient the symptoms of hypothyroidism and to seek medical help if these symptoms occur. RAI therapy is usually given on an outpatient basis. A pregnancy test is done before the starting therapy for all women who have menstrual cycles. Tell the patient that radiation thyroiditis and paroiditis are possible and may cause dryness and irritation of the mouth and throat. Relief may be attained with 3 quarts of water, ice chips, and a salt and soda gargle 3 to 4 times a day. This gargle made up of dissolving 1 teaspoon of salt and 1 teaspoon of baking soda and 2 cups of warm water. The discomfort should subside in 3 to 4 days. A mixture of amino acid mylanta, diphenhydramine, and viscous lidocaine can be used. This is also known as magic mouthwash, if you've never heard it. It can be used to squish and spit, increasing patient comfort when eating. To limit radiation exposure to others, teach the patient receiving RAI home precautions, including using private toilet facilities if possible, and flushing 2 to 3 times after use. Separately laundering towels, bed linens, and clothes daily at home. Not preparing food for others that requires prolonged handling with bare hands, and avoiding being close to pregnant women and children for 7 days after the therapy. So indications for surgical therapy. So a thyroidectomy is done for those who have 1, a large goiter causing tracheal compression, or 2, a lack of response to the antithyroid therapy, or 3, thyroid cancer. Surgery may be done when a person is not a candidate for RAI. One advantage that thyroidectomy has over RAI is the more rapid reduction in T3 and T4 levels. A subtotal thyroidectomy is preferred for surgical procedure. It involves removing a significant portion, about 90% of the thyroid gland. Some patients may undergo minimally invasive endoscopic or robotic thyroidectomy. Endoscopic thyroidectomy is appropriate for patients with small nodules, less than 3 centimeters, and no evidence of cancer. Robotic surgery is best for those who are not overweight and have small nodules on only one side of the gland. The advantages of endoscopic and robotic procedures over open thyroidectomy include less scarring, less pain, and a faster return to normal activity. So here you can see the before and after if they do a subtotal thyroidectomy. Nutritional considerations. With the increased metabolic rate in the hyperthyroid patient, there is a high potential for the patient to have nutrition problems. A high calorie diet of about 4,000 to 5,000 calories a day may be needed to satisfy hunger, prevent tissue breakdown, and decrease weight loss. This can be achieved with 6 full meals a day and snacks high in protein, carbohydrates, minerals, and vitamins. The protein content should be 1 to 2 grams per kilogram of ideal body weight. Increase carbohydrate intake to compensate for increased metabolism. And carbohydrates provide energy and decrease the use of body stored protein. Teach the patient to avoid highly seasoned and high fiber foods because they can further stimulate the already hyperactive GI tract. Have the patient avoid caffeine-containing liquids such as coffee, tea, and cola to decrease the restlessness and sleep problems. Refer the patient to a dietitian for help in meeting individual nutritional needs. Your nursing assessment. If you look in your book, subjective and objective data should be obtained for a person with hyperthyroidism, and this is outlined in table 49.10. Nursing diagnosis. Nursing diagnosis for the patient with hyperthyroidism include activity intolerance, impaired nutritional status. Additional information on nursing diagnosis and intervention is presented in your e-nursing care plan online through your textbook for the patient with hyperthyroidism. Planning. The overall goals are that the patient with hyperthyroidism will have relief of symptoms and have no serious complications related to the disease or treatment. We're going to maintain nutritional balance and cooperate with therapeutic plan. So now we're going to look at some NCLEX style questions. Okay, so just look at each one of these on your own and review them. I will upload the slideshow that has the actual answers to each one of these slides.